into something you probably never see, but that affects all of us, the invisible data architecture of the NHS.
That's right. We're talking about clinical coding.
And how, fundamentally, the notes your doctor writes become the currency that keeps a hospital running.
Exactly. Our mission today is to trace that journey, how raw clinical information gets transformed into these quantifiable units for payment and, for national analysis.
And the whole thing stands or falls on data integrity.
It's everything.
Yeah.
And it starts with two core systems. There's ICD-10, which is the global standard for diagnoses.
Okay, so that's for, tracking diseases, things like I-50.0 for congestive heart failure.
Precisely. And then for procedures, the actual interventions, the NHS in England uses OPCS 4. So a code like M72.1 might be a partial urethrectomy.
And there are actual people, accredited clinical coders, whose entire job is to be the translator between the doctor's notes and these code books.
Yes, and that translation is the single point of financial risk for a hospital. Get the code wrong, the trust gets paid the wrong amount. Simple as that.
Okay, let's unpack this a bit more. So once it's all coded, that information creates the currency of the NHS Payment Scheme.
Healthcare resource groups, or HRGs.
HRGs, so what are they exactly?
Think of them as price bands. An HRG groups patients together based on how many resources they're expected to use. So, what it should cost to treat them.
And how is that assigned?
It's done by a piece of software called the Case Mix Local Grouper. It's sort of the NHS's black box accountant. It takes all the codes from your hospital stay and figures out which cost bracket you fall into.
But here's what I find really interesting. What happens with really expensive things, like a new high-cost drug or a very advanced scan?
Right. So that's what's called unbundled activity.
Unbundled.
The grouper is smart enough to pull those high-cost items out. It isolates them so they can be paid for separately.
I see. So the cost of a brand new gene therapy doesn't completely warp the standard price for, say, a routine procedure.
Exactly. It prevents those outliers from inflating the core HRG price.
But there's a huge problem under all this, a structural constraint. I was reading that the price setting is based on seriously lagged data.
That's the Achilles heel of the system. We're talking about using cost data from 2018-19 to set the prices for the 2025-26 tariff.
Wait, a 6 or 7 year lag? In what other industry would that even be possible? With inflation, new tech?
It's not really viable, and that's why the system needs manual overrides. It's the only way to cope.
A manual override, so someone just steps in and fixes the numbers.
In a way, yes. They have to apply central manual policy adjustments to fix what they call implausible prices or illogical relativities, where the computer model spits out a price that just makes no clinical sense.
Can you give an example?
Sure. For the upcoming tariff, they had to apply a blanket 15% uplift to a whole group of gynecology HRGs. It's proof that the pricing is really a hybrid of data modeling and, policy fixes.
So this coded data isn't just about getting paid, it must have a wider use.
Oh, absolutely. It all feeds into national planning through something called Hospital Episode Statistics, or HES.
HES, that's the massive national database, right? It has everything. Diagnoses, procedures, even demographic data.
Everything. And that's what policymakers use to plan for the future. But that brings us to a huge strategic risk.
Let me guess. Opt-outs.
You got it. The GDPR controversy, where millions of patients opted out of their data being shared, that introduces systemic selection bias into the very data sets we need for planning.
So what's the bottom line here? If the data is biased,
then the epidemiological models we build from it will be inaccurate. It compromises our ability to plan for the nation's health or allocate money efficiently.
The whole system then really hinges on getting that coding right in the first place, right? First-time coding, as they say. What's the solution?
It has to be shared accountability. You can't just leave it to the coders. Trusts need to formalize it, to incentivize clinicians, the doctors and surgeons, to actually get involved in validating the coded data.
So moving the responsibility upstream, back to the person who wrote the note.
Exactly. You fix it at the source.
Right. That makes perfect sense. So to bring this all together, this clinical coded data is the one single point where patient care, hospital finances, and national health policy all converge.
It is the core financial and strategic language of the NHS. And I think the final thought to leave you with is this. The fact that the system relies so heavily on manual policy fixes to get around that massive time lag in costing data, it shows the financial stability of the NHS payment scheme depends less on automation and more on, human intervention.
So the biggest strategic improvement isn't more software?
No. It's investing to close that 2018 costing gap. If you could do that, you'd need far fewer overrides, and the system could finally be truly data-driven.